mobilizing dispensing funds. But when you're not doing that, he's here today to mobilize and dispense knowledge. Dr. Chris Baraza, I think the floor is yours. You can proceed. Hello?
Yes, apologies for the interruption. I don't know whether Dr. Chris is with us. I saw him in the chat, but I think he has dropped off. I can see he has joined us again.
Maybe you can give him 1 minute. He tries to organize himself. If he doesn't, then maybe you can go to the second presenter.
All right.
Because it will make more sense when the presentation flow in that order.
All right. Dr. Chris, kindly confirm whether you can hear us. You can also unmute your mic.
And then maybe before Dr. Chris start, I'd like to indulge the audience or request them that if you have any questions, I think I propose that we can handle them at the end of both presentations, if that's admissible to all of us.
Yes, that's okay. We'll be handling questions after the presentations. Kindly, if you have any question, post them on our Q&A. Our presenters will pick them up after their presentations. Thank you.
Yeah, thank you, Daktari. Just confirm you can hear me.
Loud and clear.
Thank you so much for the opportunity to have this discussion. And thanks, Dr. Yengo, for reaching out, for me to share some of the thoughts that we've had in relation to the practice of oncofertility, the present, the past, the present, and the future. So I'll approach it from a slightly, this perspective that I'll do a bit of introduction to this. And then I'll also look at it from a programmatic perspective. What does it mean for us? Because at the end of the day, we must think through whatever we discuss here, what does it mean to our country, Kenya, and what are the next steps that we must undertake? Then my colleague, Yvonne, will be able to delve a bit deeper into the clinical aspects of it. So as a way of introduction, this is the outline, and just an introduction, the past, the present, the future. But just starting by quote by Elder Russell, who said that there's no role in life more essential and more eternal than that of motherhood. And being a practicing fertility interested person, one of the most devastating moments is when a woman comes to you and they've been married for the last 1 year or 2 years, and then they say they cannot be able to get pregnant. When you delve further into it, you realize that probably they underwent some procedures or some treatments or somewhat because of age, they're not able to actually conceive. And it becomes a vicious cycle of devastation. Make matters worse is if they can't be able to conceive by themselves, and they may require IVF. It becomes very, very complicated, psychologically traumatizing to this. Worse still, if they are getting to the age of menopause, around 36 to 40, and they're having features of premature ovarian dysfunction, then it becomes even more complicated because the options you have now become very limiting for that matter. So cancer treatment poses a threat to fertility, whether it's through chemotherapy, radiotherapy, or even surgical interventions that may still pose a threat to fertility. And there are potential treatment-related infertility aspects that I won't go into in detail. Oncologists, unfortunately, seldom discuss fertility concerns. Of patients, and there are quite a number of studies that have definitely shown that the most immediate concern to most oncologists usually is managing of the cancer, but we forget just confirm I'm back. I think I lost at some point. Okay, thank you for
Yes,
that.
you're back,
So
Dr. Chris.
just mentioning that we seldom discuss this, and studies have shown that most of the times we actually don't think about what are the effects post-treatment for cancer. So you manage one condition only to leave the patient with a lifelong psychological effect that definitely affects the quality of life. Just the way I've mentioned that not having children for any woman who wishes to have children is one of the most psychologically impactful issues that anyone can face. Then common cancers in women, less than 35 years, we've come across breast cancers in early ages, melanomas, cervical Hodgkin's lymphomas, leukemias, and all these may expose women to treatment. I wanted to include here sickle cell disease because it's one of the things that is coming out. It comes to bone marrow transplant and the effects that the chemo treatment for bone marrow transplant has on fertility issues among these women. So studies have shown that 16 to 85% women risk early ovarian failure. And Yvonne will talk a bit more into this, but depends on the agents that you are using, with alkylating agents being much more eventful to the ovaries. The dose that we have used is also relevant, and then the combination treatment that you may have. In breast cancer, the chemotherapy, anthracyclines, and taxane-based regimens, and taxanes have less effects to that. There are some fertility concerns that we have among women who have undergone treatment for cancer, and some of them have amenorrhea, some of them develop menopausal signs and symptoms, and then ovarian failure, that 59% of them develop within a year or so. So in terms of ovarian function, I wanted to just take us back to this so that you can have an understanding of what are some of the things that we do when you are doing an assessment for fertility. I just want to mention the role of AMH. AMH is a critical hormone that has been studied for many years, and it usually predicts ovarian function very early on. Inhibin B, estradiol, FSH have also been used, but these ones actually predict late ovarian failure. So there are hormones that you don't want to really start on with when you are assessing women, either pre-treatment or post-treatment. But AMH has been comparable both qualitatively and quantitatively assessing the ovarian functions. And it's a hormone that actually most of us in the fertility area really use a lot, and oncologists also use a lot in terms of just preparing patients for treatment. This is just a nomogram of AMH, but this was done in the US. That tells you basically that we have a steady decline of AMH levels with age. And by the time a lady reaches 40 years, then you find that we are reaching levels that are commensurate to just reduction in ovarian function. Mark you, I'm not using the word predictor of pregnancy, but I'm using the word predictor of ovarian function because there are a lot of misnomer out there. Women come to you and you tell them you can't get pregnant because your AMH levels is low. So there's no study that has shown AMH as being a predictor of pregnancy, because there are many other factors that one may consider, but it's a predictor of ovarian function for that matter. So there are quite a number of ovarian reserve tests that we undertake, usually qualitative and quantitative assessments. And then there are some biochemical assays that we do. So for this, the first one, usually do androfollicular count. We just look at how was the size of the follicles, how many are they, and at what stage are they in the cycle. Then you have biochemical assays. I've talked about AMH, FSH, estradiol, and inhibin B. So based on the AMH as a predictor of ovarian function, usually there's a plateau between the age of around 13 to around 30 when we start having a steady decline in the levels of AMH. So ovarian replacement therapy is mostly done in IVF settings, and patients on chemo treatment are at high risk of developing premature ovarian function or failure. And these affects, as I mentioned earlier, self-esteem, quality of life, because we start having menopausal symptoms much earlier. There's need for us to have an increased understanding of a woman's reproductive potential, even as we discuss cancer and treatment of these women. Pre-chemotherapy counseling and fertility preservation is extremely important. And some centers have actually gone ahead to develop this in the cancer units so that they can be able to really assess a woman's reproductive potential before they start them on chemotherapy. I'm not so sure in this country we have any center that has very well established pre-treatment fertility assessment. And this would be very, very helpful for us to be able to assess the woman's potential to get pregnant. And therefore, I mean that there's positive data in developing countries in relation to this. My MA thesis was basically on this, and I looked at women who had undergone chemo treatment for breast cancer, and I looked at women who were less than 40 years, so up to that 9 years. Despite the fact that my sample size was relatively low because of the high cost of conducting AMH, but two things came out clearly, that even among women after exclusion criteria, among women who were supposedly normal, about 22% of them actually had a reduced response based on the AMH levels that we have. Well, what that means is that they are likely to develop premature ovarian failure. All the women that had been treated, the chemotherapeutic agents, most of the times we use alkylating agents in Nairobi, because the study was multicentric. We did in Nairobi Cancer Treatment Center. We also did it in KNH and also Texas Cancer Treatment Center. So what we found is that none of the women actually had either normal response or excessive response among those patients who had been treated with for cancer of the breast. There was also a positive correlation between AMH levels and period to resuming menses. Again, menses is not a direct indicator of ability to get pregnant, but it's an indirect measure of the functionality of the endometrium, for that matter, and the ovarian function. So as much as there are those women who may be menstruating, but they are still subfertile. There are those who may not be having menses, they may be amenorrheic, but still able to conceive. So, but it's a measure of, clinically speaking, when we are following up women that we have treated with cancer, amenorrhea becomes, or the resumption of menses becomes a good indicator from a clinical perspective to just follow up on what could be the other potential effect that this may have had on the endometrium. This culminated again into a PhD. So what I'm looking at currently is to assess the anatomical, vascular, and functional aberrations of the female reproductive tract organs following chemoradiotherapy among childhood adolescent cancers in Kenya. So we want to look at what are the anatomical variations, looking at the size, shape, and volume of the uterus and ovaries, because radiotherapy especially has an effect on the size of the uterus. And sometimes it leads to scarring the cervix. If we do pelvic radiation for some of the tumors, resistive index studies of the uterine and ovarian vessels just look at what are some of the alterations on the vasculature that may affect the uterine function and ovarian function, then AMH and inhibin levels, then do a correlation with the size, shape, and volume of the uterus. So these are ongoing study. Those are my supervisors, and I really want to appreciate Prof. Mozo Bimbo, Innocent Maranga, Jojo Gweno, who may be on this call as we speak. So why oncofertility? It refers to an interdisciplinary field that bridges oncology, reproduction, and women's health research for the purpose of exploring and expanding options for the reproductive future of cancer patients. These are terms that was coined in 2006 by our friend Teresa Woodruff at the Oncofertility Consortium and funded by the National Institute of Health Roadmap Grant. And it's domiciled in the Northwestern University in the US. They usually have an annual conference. Last year, my colleague, Dr. Gweno, represented us in this. And there are quite some exciting discussions going on for the last almost 20 years, just in relation to what are some of the dynamics. So basically mixing between oncology and fertility to coin the word oncofertility. And what that means, balancing life-preserving treatments with fertility-preserving options. So we must be very intentional in whatever we are doing, even as we treat patients who may have cancer, but need to have children in the future. So why fertility? Because advances in cancer management has led to improved long-term survival. Childhood cancer survival rates have significantly improved. There's a younger age diagnosis of cancers, largely premenopausal, either due to early screening or due to, the awareness of the population in relation to, what are some of the early signs of, let's say, developing cancer of the cervix. So we are seeing gradually that there's an incremental, reduction in the age at which these women are being diagnosed with various cancers. So the consortium basically looks at how can you have a multidisciplinary team to assess a woman who is being treated for cancer. And the fundamental question is what regulates follicular growth and oocyte maturation, and how can eggs and follicles be preserved without damage. So what this diagram depicts is what the Fertility Consortium went through to just look at the practice. And from a policy perspective, these are things that we need to start discussing as a country, so that as you're assessing a woman who has cancer, are you also looking at the family, the parents, and that cancer survivor? Is there an unmet need in terms of preservation of fertility options after cancer? What are the options that we have, and what are the treatments that we have? Because if we push and have a policy, a law that can guide in terms of reducing the cost of doing IVF, then that's the way to go. Community engagement, education, and looking at just the resource pipeline that we have at a national level. The information gaps that we have, just looking at how siloed are we? Because more often than not, as doctors, and I want to say this because I'm one of us, we usually think in silos, that we are the nutritionist, we are the fertility expert, we are the oncologist, we are the hematologist. And that may be because of multiple factors, but just embracing a multidisciplinary aspect where we can have an oncologist, reproductive endocrinologist, we can have people in research who can be able to really guide, and just linking this up with the government in terms of regulations, and just the state functions in terms of looking at this woman holistically for us to be able to manage all the aspects of her care, including fertility concerns that she may have. The vision statement for the Fertility Consortium is basically what I've put there. I'm not going into the details, but the application is basically the consortium looks largely at cancer survivors, look at patients who have undergone bone marrow transplant, and patients have undergone other chemotherapy treatments. For instance, quite a lot of interest in terms of what's the effect of hydroxyurea on patients' fertility among those women or girls undergoing treatment with sickle cell disease. So what are some of the aspects that we may want to consider? I just wanted to mention this guideline, and I think it's going to be relevant to us even as we think through furthering the oncofertility aspects in our treatment centers. The Anderson Cancer Center has a very robust guideline that looks at what is the pre, intra, and post-treatment, aspects of fertility that the patient should be considered for. And there are quite a number of things that we look into. They give, provider is defined as physician, so they give important information to the client before, during, and after treatment. They assess need for, psychiatric and reproductive medicine psychologists, financial counseling, other options in terms of fertility and parenthood. They do that. Then they give options for preview of what they actually do, and it walks the patient treatment. And it's a very exciting journey that you walk with the patient through as a collective responsibility, just looking at what are some of the fertility concerns that this patient may have, and are you going to refer them to the necessary people? And here you want to ask yourself, are they eligible for fertility preservation? Yes or no? Which method are they going to be eligible for? Is it benign cancer treatment? Give recommendations, individual care based on clinical indications. And then you are able now to just have a holistic approach to managing this patient. And even when they come back after treatment, looking at the different options that I'm going to talk to next, then you can be able to really guide as expected. So some of the fertility preservation options in females that we have, and I won't really focus a lot onto this because I know my colleague will talk to this again. We have medical, we have surgical aspects. The medical aspects usually we look at embryo cryopreservation, and this basically involves harvesting eggs, IVF, and freezing of embryos for later implantation. And this is the most established technique, fertility preservation in women, has been undertaken for many years. And this is based on the US aspects. Requires about 10 to 14 days of ovarian stimulation from the beginning of menstrual cycle. And this is important information. So that as you plan treatment for your patient, and they also tell you they need to have embryo cryopreservation, you need to have some lead time, just about a month for you to be able to do the harvesting before you start them on treatment. So if the tumor is rapidly progressive, then you need to think through, depending on the type of tumor, what are some of the things that you may need to do to slow down probably the tumor progression as of the preservation until just about 19. This was still experimental, but around 2019, this was now proven to be something that can be done clinically. And what you do is harvest and freeze of unfertilized eggs, and requires about 10 to 14 days also for ovarian stimulation. Ovarian preservation and transplantation. And there are a few concerns in relation to this, especially where we have cancer that may be affecting, let's say, the ovary. So you want to ask yourself, when I do reimplantation, will I still be spreading the tumor for that matter? So the same day outpatient surgical procedure. I think Yvonne will talk about this a bit more. Gonadal shielding during radiation therapy, that's use of shielding to reduce the dose of radiation delivered to the reproductive organs. This has been published in terms of case series. And this is only possible when you have very targeted radiation and at a low dose, because they're different. The ovarian tissue, just about 2 grays of exposure may actually lead to ovarian damage and premenopausal, or rather menopausal premature ovarian failure for that matter. We need expertise, as I mentioned there, is required to ensure shielding does not increase dose delivered to the reproductive organs. Ovarian transposition, that's for PEXI. I'm not going to detail about that. I know you want to talk about that. Chirurgical surgeries, you also talk about this. Minimization of normal tissue resection. It's very important as we do the pelvic organ surgeries. Need to be a bit careful, a bit nice, and careful when you're handling the reproductive organs, because a bit of too much trauma can actually affect ovarian function and even the uterine function for that matter. Then ovarian suppression with gonadotropin releasing hormones. The use of hormonal therapies to protect ovarian tissue during chemotherapy, radiation therapy. This has been done in small randomized studies. This is a study going on currently that is a bit of large randomized study. It'll be interesting to see what this gives us. So as I come to us, the present basically is just looking at how can we be able to form a local, fertility consortium that can be able to guide this. And some of the bottlenecks that we currently have in our country is the legal alignment, just looking at what are some of the policy frameworks that guide this in terms of, tissue transplant. And I'm glad I'm part of the team that's looking into this, just looking at policy guidelines and the legal framework to be able to, we had about 3 weeks ago to just look at what are some of the policy guidelines that it will guide in as far as some of these interventions are concerned. What are some of the ethical issues? You know, ethical issues are very critical in this kind of discussion. I've had religion and IVF. I've had issues to do with cryopreservation and just developing a community of practice.
I think you have lost Dr. Chris again. Seems like his network is quite unstable, but he was almost at the tail end of his presentation. I think the best thing to do is we move forward to the next presentation by Dr. Yvonne Wekesa. Dr. Yvonne Wekesa is a consultant obstetrician gynecologist at the Kenyatta University Teaching and Research and Referral Hospital. She has holds a bachelor's degree in medicine from the University of Nairobi, MD in Obs-Gyn from Makerere University, a diploma in tropical medicine from London School of Hygiene and Tropical Medicine. She has a teaching experience in areas of disaster medicine, family medicine, and maternal health, having served as a part-time lecturer with the London School of Hygiene and Tropical Medicine. She's currently pursuing a gynaecology fellowship at the University of Nairobi. Our topic is going to touch on areas of fertility preservation in cancer patients, or rather cancer survivors, and mainly reproductive organ malignancy, that is gynae malignancy. Dr. Yvonne, kindly proceed.
Thank you very much, Dr. Yengo, for that introduction. And although we lost Dr. Baraza, I must appreciate his introduction to the topic. If my slides are clear, I'll start. So I'll be talking about fertility preservation in cancer survivors and specifically focusing on gynaecology malignancies, as well as a little bit on chemotherapy and radiotherapy and the effect on fertility. So why is this important? I think Dr. Chris mentioned some of this, but we are seeing more and more patients diagnosed early in their reproductive age with cancer. And because of these advances in diagnosis and treatment, we have patients surviving for a longer time with a higher cure rate. And therefore, they are faced later on with the option of either facing infertility or early menopause. And also, we know that more and more women, especially in our setup, are delaying motherhood to their 30s and 40s, and therefore this becomes even a bigger problem. That's just a slide that shows, this was actually done in the US. They followed up these trends in fertility from 1990 to 2013. And we can see that this could be, relatable even in our setup, that we are seeing more and more women 40 years and above choosing to delay their fertility journey. So I'll start with this summary of fertility preservation options. So I'll specifically be dealing with the fertility sparing surgeries in this presentation, but what Dr. Baraza was talking about, ovarian reserve and ovarian cryopreservation techniques are also part of this fertility preservation options in these women, but I'll specifically focus on the cancers, cervical cancer, endometrial cancer, ovarian cancer, and the options that we have to preserve their fertility. We know that cancer by itself or the drugs that are used, the surgery that is done, or cytotoxic drugs or radiation therapy, all of this could cause damage to the HPO axis, the hypothalamo-pituitary gonadal axis, as well as the reproductive organs directly. And this could lead to infertility in these women. And the magnitude of this risk obviously depends on multiple factors, including genetics, age of the patient, and side effects of the treatment, including hypothyroidism. So this graph on the right just emphasizes that chemo and radiotherapy greatly increases the chance of patients getting to premature ovarian failure. And therefore, this is a concern to us who are treating these women.
Yvonne, sorry.
Yes.
Your slides are not moving.
Oh, just a minute. Not sure if that's, you can see the slides?
Yes.
Sorry, I might not be able to, I don't know whether it's appearing in slideshow or not, but if you can see them, then we can proceed. So I was talking about the options that we have in terms of fertility sparing surgeries, and I'll go straight to fertility sparing surgery in cervical cancer. So we know that up to 28% of cervical cancer is diagnosed at age 29 to 39 years, which is the prime of our reproductive age. And 45% of the surgically treated early 1B cervical cancer occurs in women who are less than 40 years. The options that we have in these patients with early cervical cancer, and we'll look at the criteria later, include conization, which is just resection of a portion of the cervix, where a cone-shaped portion of the cervix is resected. We also have simple trachelectomy, which simply implies removal of the entire cervix. We have a radical trachelectomy, which is the removal of the entire cervix and part of the parametrium. And this can be done either vaginally, abdominally, or laparoscopically. And apart from those, we also have patients with a more bulky disease that can be managed by neoadjuvant chemotherapy, which will allow this tumor to shrink and then make them eligible for conservative surgery as outlined above. So there's a very strict criteria for eligibility of these patients, obviously because of the risk of recurrence. We look at some pathological findings and others to classify these patients as eligible for fertility sparing surgery. So the major one is the size of the lesion. So most of the studies have looked at fertility sparing surgeries in stage 1B1 tumors. So stage 1B1 simply means a macroscopic tumor that is less than or equal to 2 centimeters. And therefore, any patients who have a tumor that is more than 2 centimeters, that is from stage 1B2, have been found to have a much higher unacceptable risk of recurrence. So that's one of the criteria. And number 2 is low risk cervical cancer histologies. So the low risk cancer histologies include squamous cell carcinoma, adenocarcinoma, and adenosquamous carcinoma. The ones that are aggressive histological types like the serous type, the carcinoid, the small cell, those are not eligible for this kind of surgery. And then we also need to make sure these patients have negative lymph nodes, and also on the imaging prior to the surgery, we need to have at least a margin of 1 centimeter from the tumor, so that this allows you to have a surgical tumor-free margin of at least 5 millimeters on the final pathological specimen. These patients obviously have to have a desire to preserve their fertility, and they have to be in the reproductive age group. This has been gradually moved from less than 40 years to up to 45 years. And that last statement there is just emphasizing that for patients who have tumors that are more than 2 centimeters in terms of size, they've been found to have up to 3 to 4 times more risk of recurrence if they're subjected to fertility sparing surgery. This summary in this table it's by in no means completely, captures all that we think about when we are choosing a procedure for a patient, but it's a guideline that mainly patients who have very early stage, that is 1A1, which is a microscopic tumor with the stromal invasion of less than 3 millimeters, they could get away with only conization as a curative treatment. And this is because these patients have no lymphovascular space no LVSI lymphovascular space invasion, and they also do not have, they have a very low chance, less than 1% chance of metastasis to the lymph nodes, less than 1% chance of extension to the parametrium. So you could ideally do a conization and cure this patient. The other procedure is a simple trachelectomy with the same, for the same cadre of patients, no LVSI, stage 1A1, but we allow a slightly bigger tumor up to 2 centimeters. And these patients, it's recommended that you ensure, the most important thing here is to get margin. So at least 8 to 10 millimeters of normal tissue around this cancer, but up to 5 millimeters is acceptable in some circumstances. And these patients require endocervical curettage afterwards, just to ensure that you do not have tumor extension into the endocervical canal. For patients who have any type of LVSI, so LVSI simply means tumor cells in the endothelial cells in those luminal spaces of the endothelial cells. So when you have LVSI, there's a chance of lymph node involvement. So patients with stage 1A1 disease with LVSI, patients with stage 1A2 disease, 1B1, and 1B1 is our cutoff for that 2 centimeters I was talking about. The treatment of option there is a vaginal radical trachelectomy. And just as a caveat, these patients need to have lymph node assessment. All these patients need to have lymph node assessment. And as well, I'll talk about frozen section in a bit, but just to remember that you need to have your margins as well, 1 to 2 centimeter of vaginal mucosa, which is the distal margins, and then the radial margins, which is the parametrial tissue. For patients who have a more than 2 centimeter tumor, that is 1B2 and sometimes up to 1B3, these patients, and it's still with, that means it's 1B3, it's still within the cervix, it hasn't gone to the vagina or anywhere else. They are non-optimal candidates, again, because of that risk of recurrence that I talked about. But for these patients who insist or are very keen on fertility preservation surgery, there are 2 options. One is a neoadjuvant chemotherapy, which would shrink this tumor to the levels that would make them eligible for fertility sparing surgeries, which means that after this neoadjuvant tumor, this tumor has to be 2 centimeter or less to qualify. And then number 2 is you can go ahead and do an upfront abdominal radical trachelectomy. So the difference between this abdominal radical trachelectomy is that with abdominal radical trachelectomy, you have a wider parametrium. That is, it's a more morbid surgery, but you have more wider parametrial dissection, and therefore it could be used for bulkier tumors. And also it is an advantage in our setup because, as you know, we still have a challenge with the laparoscopy skills. We still have a challenge with vaginal surgery sometimes in some setups. Therefore, this one, it has a shorter learning curve, and it's actually been touted to be the procedure of choice for resource-limited countries. And it's technically easier and also possible in patients who have some sort of anatomic distortion and in those in whom vaginal access is not possible. And the disadvantage of this abdominal radical trachelectomy, like I said, it's a more morbid procedure, therefore greater blood loss, longer hospital stay, and also you have to sacrifice the uterine arteries bilaterally most of the time, which may cause issues with fertility, endometrial atrophy, cervical stenosis, and which will affect the future pregnancies. Therefore, it's a delicate balance when you're talking about radical trachelectomy and the options. It's a delicate balance between better oncologic outcomes and versus worse fertility outcomes. I'll just go back to this slide about frozen section. Because I know that frozen section is not widely available in our setup, but this is very important for patients who you're going in for a fertility sparing surgery, but the lesion, you find a macroscopic or a visible lesion, or you're in doubt of you're in doubt of the margins during your fertility sparing surgery. So it's recommended that these patients get immediate frozen section while the patient is intra-op, so that you're able to tell whether you have negative margins, and you're able to go back during the same procedure and excise a wider area. Or you abandon the procedure. For example, if you look at the lymph nodes and they're positive, you abandon the procedure and let the patient get chemoradiation. So frozen section is something we can discuss. I know we have gynecologists who have joined in, and maybe later on they can weigh in on the experience and how to go about this. I hope I'm still being heard and my slides are moving.
Yes.
Okay, so there's this slide, I put it up just because I was looking at conization as a procedure that is quite, easy to do and easy to teach, and available in our setup. And therefore, I just went through the steps of what is done during a conization, and maybe later on, if anyone is interested with that, they can look at it. So all the patients who go through fertility sparing surgery need to be counseled that this might not be, curative, because after this has gone to pathology and the histology comes back, we need to look at it to make sure that they are not at risk of recurrence. And we have this criteria that we use in gynecology, the Peters criteria, which is the high risk criteria, and the Sedlitz criteria, which is the intermediate risk criteria. So if a patient, I will not really belabor you with the details, but if a patient falls under any of this, the patient requires adjuvant therapy. So additional therapy will be done. In this case, it will be adjuvant radiotherapy, which is for local recurrence. Now, if this patient is still interested in fertility sparing surgery, then you need to counsel them about what Dr. Chris was talking about, ovarian transposition or egg harvesting before radiotherapy. And if they're no longer keen on fertility sparing surgery, then you can still go back in and do definitive hysterectomy. The follow-up for these patients, again, is very important because, as you know, we still have that risk of recurrence. So these patients, every 3 to 4 months, should be seen with ideally a cervical cytology, HPV co-testing, and colposcopy, plus or minus endocervical curettage, depending on the tumor that you have and what you had, the histology type that you had before. And also, after every 6 months for the next 2 years, and then yearly afterwards. So fertility outcomes with the fertility sparing surgery have been quite, I think they are commendable, because when you look at this systematic review that looked at stage 1B1 patients who are subjected to either simple trachelectomy or con resection, radical trachelectomy via the vaginal approach, laparotomy approach, and laparoscopy approach, the recurrence rate, as we explained, was a bit lower for the laparotomy approach, 2.4% there. And this could be explained by what I talked about, more extensive parametrial, assessment and lymph node assessment. And then for the recurrence rate of laparoscopy was the highest in this systematic review. When you look at the pregnancy rate and live birth rates, again, as expected, the less invasive procedures like simple trachelectomy and con resection have a higher pregnancy rate and live birth rate. And we have a lower pregnancy rate and birth rate with laparotomy. Again, you can look at these studies, but just to say that these patients have been followed up and there's hope in terms of fertility outcomes. So pregnancy after fertility sparing surgery in cancer of the cervix, preferably we advise them to wait 6 to 12 months to attempt conception. And then these patients will just require serial monitoring of their cervical length, as well as administering antenatal corticosteroids when indicated. Definitely MFM specialists should be on board for the management of these patients. And in terms of route of delivery for conization and simple vaginal trachelectomy, SVD is the route of choice. especially because we don't routinely put a sacrilege for conization. Radical trachelectomy, we advise for cesarean delivery at 37 to 38 plus 6, because they usually have a permanent sacrilege in place. Okay. And I just put up this slide because in terms of counseling, these patients need to be counseled about possible side effects, because the fertility sparing surgery itself could also impact on fertility. So the cervical stenosis rate with conization was about 1.3 to 24%. So this variability is very, as you can see, very wide, and it's likely because there's really no standard definition of what cervical stenosis is. And there's a lesser chance of cervical insufficiency, and this is directly related to how much tissue is removed at the time of the conization. For the radical trachelectomy, there are two things. One is the mechanical, the weakness of the cervix because of how much tissue is removed, and therefore you can have second trimester losses, preterm labor, but also there's an interference with the mucus plug. And this mucus plug usually provides protection from ascending infections and may predispose these patients again to PPROM and preterm labor. So in terms of directly impacting fertility, this trachelectomy, radical trachelectomy, also has been associated with infertility due to cervical factors. Up to 45% will experience cervical factors, and they might still need assisted reproductive techniques in addition to, everything else. So I'll go straight to, I've dwelled a lot on the cervical cancer because, as you know, that is our commonest, the commonest one in our setup. But I'll quickly go through endometrial and ovarian cancer. So endometrial cancer is ideally not a disease of the young. It's mostly found in the postmenopausal age group, but up to 4.5% of women diagnosed with endometrial cancer are younger than 40 years of age. So the eligibility here is that this, so I really wouldn't say fertility sparing surgery in terms of endometrial cancer. I would say conservative management in endometrial cancer, because the option in the endometrial cancer, as you'll see, is oral progestins and progestin-related treatment. So for eligibility here, we look at patients who are grade 1 of endometrioid adenocarcinoma. So I know those who are in the oncology space know that there's a new classification for endometrial cancer, 2023, that has been a bit confusing to many people, but there are histological subtypes that the least they can be in terms of staging is 1C. So the aggressive histological types like serous, the least they can be is 1C. So here we're talking about stage 1A endometrioid adenocarcinoma, that's grade 1. And then this patient should be in the reproductive age, desirous of future childbearing. They should not have contraindications to hormonal therapy, and they should understand that this is a non-standard way of managing their endometrial cancer. Because as you know, for full staging of endometrial cancer, we need surgical staging, and which will not be done in these patients, and therefore they do not have proper, complete evaluation of their endometrium. Another thing is patients with Lynch syndrome, which is a genetic syndrome where you have mismatch repair genes defect, are not eligible for this because their issue is more the genetic as opposed to excessive estrogen stimulation. And usually they have a poor response to progestins. So the pretreatment considerations, of course, in addition to your medical history, family history, molecular screening for Lynch syndrome, we advise that this patient should be counseled that there's a chance, especially in the premenopausal women, there's a chance of synchronous primary cancers of the ovary. And in premenopausal women, it can go as high as 29%, having a synchronous ovarian malignancy. So in your evaluation, imaging, and all that, you need to have that at the back of our minds that there's that chance. And then also these patients, the endometrial sampling should be done by DNC. So D&C as opposed to Pipel, because I know that most of us are able to do Pipels in the office, which is well and good for diagnosis of endometrial cancer. But in this setup, patients who are eligible for fertility sparing options need D&C because it's better for grading. And you really need to make sure that these patients are grade 1, not anything above that for this to work. So D&C is the method of choice in terms of endometrial sampling. So I'll quickly go through this. There's no consensus in terms of which progesterone to use, what schedule to use, what dose, how long, to use this. But I looked at some guidelines that were combining the levonorgestrel IUD. In our setup, we have the Mirenas with the oral progestins, and this method actually seemed to be the best in terms of regression rate of early endometrial cancer. So normal schedule would look like combining levonorgestrel IUD with megestrol acetate 80 milligrams orally, and then doing this daily, because the oral progestins have been found to be more effective when used as a daily dose as opposed to cyclic dose. So these patients would be on both of this, and then you would follow them up. I think I'll have a slide on how to follow them up later. But based on this, just using progesterones and comparing this to hysterectomy, it found that patients who are stage 1A, as we had said, stage 1A endometrioid adenocarcinoma, and they were compared with patients who received progestins, or compared with patients who had a hysterectomy as their primary treatment. And what was interesting was that the 5-year survival rate was comparable, 96.4% for hormonal therapy and 97.2% for hysterectomy. And when there was a further subset analysis, it was found that even when you removed that subset that was more than 1B and above, it was equivalent in terms of 5-year survival rate between hormonal therapy and hysterectomy. Therefore, that is the guideline that patients who are eligible for this hormonal treatment should be 1A, grade 1. And also the follow-up with the fertility results and birth rates. We have many systematic reviews that you can look at, but regression rates with hormonal therapy approached in all these studies approach more than 70%, and live birth rates of up to 34.8%. The other options in endometrial cancer include hysteroscopic resection. So ideally, these patients could go through hysteroscopy. There have been some, I would say, not proven claims about, the fluid in hysteroscopy, leading to the spread of cancer through the fallopian tubes and all that. And there have been recommendations on what pressures to use with this fluid and all that. But that is an option, hysteroscopic resection, and it's been found to also improve the sensitivity to progesterones, because this patient would still be put on progesterone after the hysteroscopic resection. The other option, for patients with endometrial cancer is ovarian preservation. If these patients are beyond stage 1A, grade 1, and they still want to preserve their fertility, then you can give them the option of ovarian preservation with the later oocyte retrieval and use of a gestational carrier. This is my last slide on endometrial cancer, just looking at how you follow up these patients who are on progestin treatment for endometrial cancer. So ideally, you should see them in 3 months with an office endometrial biopsy, just to confirm whether the disease is there or not. If you have 2 consecutive negative biopsies, then these patients can be advised to proceed with, pursue pregnancy. If they do not wish to pursue pregnancy at the time and they still have risk of excess endogenous estrogen, like obesity, then it's advisable to leave the IUCD in situ. For patients who at the initial 3 months have persistence of their disease, then as you remember, there was a very wide range of the progesterone doses. So you can double the dose and then look at, do another endometrial biopsy in another 3 months, or add oral treatment if this patient was on IUD only. And then these patients that have persistence or progression after 9 to 12 months of follow-up are unlikely to respond, and therefore should be advised to go through the normal surgical staging and hysterectomy as should. So we have this, I will not go through this, but when you have time, you can go through that flowchart, just looking at the, how you follow up these patients after treatment with oral progestins. I will move on to ovarian cancers and the options that we have for ovarian cancers. So ovarian cancer, the major subtypes of ovarian cancer can be, I guess, divided into 3. We have the epithelial tumors, the sex cord stromal tumors, and the germ cell tumors. So germ cell tumors are very chemosensitive, and that is why in this eligibility criteria, we're saying all germ cell tumors, any stage, could be eligible for fertility sparing surgery. Sex cord tumors that are confined to one ovary, or epithelial tumors that are stage 1, grade 1 and 2. So it's epithelial tumors are mostly, diagnosed at advanced stage. But if you were to get, stage 1A, grade 1 or 2, then they would qualify for fertility sparing surgery. So what this means in terms of ovary is that you are able to preserve at least a part of one ovary and the uterus. But these patients still have to go through the full staging procedure. This is important, the full staging procedure, so that because ovarian cancer is surgically staged. So should go through inspection and then a unilateral salpingo-oophorectomy or cystectomy. Depending on what you find intra-op. They should go through intracholecal omentectomy, peritoneal fluid sampling, and random peritoneal biopsies. And also, just to add that if you find enlarged lymph nodes, then this should also be sampled during that procedure. And if you look at radiotherapy and infertility, for radiotherapy and infertility, our major issue with fertility in these patients is premature ovarian failure. Premature ovarian failure could be due to many things, including age of the patient. The older the patient, the more they are at risk of being affected by radiotherapy, the dose of radiation, the type of radiation. We know that now we have more precision radiotherapy devices. And then also extent of the radiation field. So predicting the age of ovarian failure, the effective sterilizing dose at which premature ovarian failure occurs increases with age. So for example, at birth, the dose that would cause premature ovarian failure would be around 20 grays, but at 30 years, the dose that would cause premature ovarian failure is 14.3 grays. So this just shows that with advancing age, you have a higher risk of being affected by radiation. I think somebody asked this question in the chat, what doses will cause premature ovarian failure. So having known that radiotherapy causes premature ovarian failure, these are the options that we have to try and preserve ovarian function. So ovarian transposition is one of the surgical procedures that we can do, also known as ovarian suspension, oophoropexy or ovariopexy. So this preserves fertility by removing the ovary from the field of radiotherapy. And this is also more important in patients who will receive chemo with low probability of gonadotoxicity, because if you're going to remove this ovary from the area of radiotherapy, but still subject them to chemotherapy that is very gonadotoxic, then that becomes counterproductive. The vascular pedicle in these cases will remain intact, as seen in that diagram. and it's different from ovarian transplantation, which we'll look at in a few minutes. And this ovary should be transposed at least 3 centimeters from the radiation field with clips to locate them, so that the radiooncologist is able to tell where the ovary is when they're giving the radiotherapy. Usually we work closely with radioncologists on this one because they have to map out the area of radiotherapy before surgery, so that you are able to transpose the ovary away from that field. The outcomes have been good with the preservation of ovarian function. Just to emphasize that there are patients who, for younger girls, when we are taking them through ovarian transposition, there needs to be, an additional, I would say, an additional method to ensure that we preserve their fertility. And most guidelines say that at the point of laparoscopy, when you're doing the ovarian transposition, there needs to be a fertility specialist to retrieve immature oocytes under transvaginal ultrasound guidance. So for young girls, their option is that these oocytes, the immature oocytes, can only be harvested at laparoscopy. So if this is planned, previously they used to do immature oocyte harvesting, but now we can also do unilateral wedge resection of the ovary, or occasionally a unilateral oophorectomy, and this can be, cryopreserved and then reimplanted back when the patient is through with the radiotherapy, sorry. So there have been several studies again that have looked at success rates with the ovarian transposition, and they're outlined in those studies there. I'm coming to the tail end of my presentation, and so I'll just quickly run through the other things that we look at when we're thinking about ovarian preservation. So apart from transposition of the ovaries and what Dr. Chris talked about, cryopreservation, we also have the concept of ovarian tissue transplantation. So these are patients, like I spoke about, who you do either a wedge resection or oophorectomy, and this is cryopreserved, and then after the patient has gone through radiotherapy, you come back and either transplant it heterotropically, which means at a site that is far away from the pelvis, or you transplant it in the ovarian area back to where it was. So that's known as orthotopic ovarian tissue transplantation. There's also the concept of autotransplantation, where the ovarian tissue is transplanted immediately. So there's no that freeze-thaw cycle. So the patient gets to, the transplantation occurs at the same time when it's, removed from the ovarian area. I hope that makes sense. And finally, I will look at chemotherapy and infertility. There are many factors that affect premature ovarian failure, that contribute to premature ovarian failure during chemotherapy, depending on the agent that is given, combination with radiotherapy, the protocol, and all this, and age. I'll just highlight this slide, which the drugs that are definitely associated with irreversible ovarian damage are the alkylating agents. We use cyclophosphamide a lot, and this is because they cause irreversible damage to the germ cells. They trigger a double-stranded DNA breaks in the cells, leading to apoptosis. Therefore, alkylating agents are quite damaging to the ovary. We have other treatments that are not as damaging, probably associated with ovarian damage and low probability for ovarian damage. And when you have time, you can look at these tables. They're available. The last part of this is to talk about gonadotropin GnRH therapy. So there has been some theories that use of gonadotropin therapy can suppress ovarian function and therefore protect the ovary. But this has been countered by the fact that ovarian follicles, although they are, quiet in terms of you're not producing, the ovary is not producing hormones when you're on GnRH agonist therapy, the follicles are still exposed to these DNA damaging agents. Therefore, it is unclear how this is beneficial, and therefore there's no quality data that reports benefit with the use of GnRH agonists. And also the long-term safety of this GnRH agonist has not been established. There are receptors generates receptors that are expressed by many cancers. And it's possible that when you use this GnRH agonist binding to these receptors, you would interfere with how the chemotherapy works, and therefore prevent the efficacy of the chemotherapy that's given. So that's something that you can read on and research, but there were some studies earlier that had said we can give GnRH therapy to sort of make the ovary quiet in other ways so that it's not as sensitive to chemotherapeutic agents. Finally, I do have this slide that looks at ovarian stimulation and the options that we have in patients with cancer. So I will go. The most important part of this study of this algorithm is the last part there that talks about estrogen-dependent malignancies. So patients who have estrogen-dependent malignancies, you would want to use different kinds of ovarian stimulation. So estrogen-dependent malignancy, you would start with tamoxifen or letrozole as opposed to the conventional agents that you use for ovarian stimulation. I don't want to go through the entire how ovarian induction is done, but just as a reminder that you should be thinking about the tumor that you have, whether they're estrogen-dependent or not, and which kind of ovarian induction to start with. For there has been concern about assisted reproductive therapy and its ability to cause ovarian cancer. And I could go through many studies, but the summary is that there has been no really consensus on whether ovarian cancer incidence is increased by assisted reproductive therapy. And also with the background that most of the patients who are infertile have other risk factors for ovarian cancer. For example, patients with let's say obesity, PCOS, they already have risk factors for ovarian cancer and therefore endometrial cancer. And therefore it would be, there are many confounders that go into looking at whether it's the ovulation induction that caused the ovarian cancer. So these are also some important studies that you can look at, but as of now, the consensus is that artificial reproductive techniques do not, or rather ovulation induction does not increase the chance of ovarian cancer. And finally, we have uterine preservation techniques. So the uterus is not as affected as the ovaries during chemotherapy and radiotherapy, but it could also be affected. And so there have been some ways that have been researched of how to preserve the uterus, especially when when the patient has malignancies in other areas that are not reproductive. So rectal cancer in young females, this is where mostly the uterine transposition is done. So what happens in uterine transposition is that the uterus is positioned in the epigastrium with the cervix connected to the umbilicus so that the patient can still have menstruation. So that's an interesting procedure that you can read up on, but it's been done. And later on, after radiotherapy has been done for these rectal cancers, the uterus is repositioned in the pelvis, and there have been pregnancies reported with this procedure. The other thing is uterine transplantation, which has been used for patients with other fertility challenges, like the transgender community, the patients with other, issues with fertility. It's not as widespread in the oncology, but it's an option because, as you know, uterine transplantation now has been done quite a number of times with successful pregnancies. And number 3 is the use of robotic radiosurgery, or the cyberknife, as we call it at KUTRH. So this is a highly precise stereotactic radiotherapy. And because of that robotic precision and accuracy, it's been There have been studies that have used it for the treatment of metastatic lesions from our gyne cancers that are, not very widespread, localized, maybe in an area that we cannot get to with surgery, or if we were to do the conventional radiotherapy, we would, affect all the surrounding structures like the ovary in this case. So this is can be performed for those patients who you really want to aim this radiotherapy and avoid toxicity. Thank you very much. Apologies for running through that last bit of the slides, but I hope that we've been able to learn something from the presentation. Thank you.
Thank you, Dr. Yvonne Wekesa, for the stupendous presentation, and also for trying your level best to break down the mental gymnastics involving this topic. I don't know if Dr. Baraza is back, and bearing in mind initially from our understanding that he works in a resource-rich setting, I thought maybe it's more facilitated and endowed with data.
I am back, Doc.
Do you want to finish on what was left? Kindly, if you don't mind,
Actually, that was my last slide, Doc. I don't think I had anything.
Thank you also, Dr. Baraza, for the presentation and quite insightful. How from this discussion, or rather from this presentation, we are going to have a clear way forward on how to handle women with cancers or patients with cancers and who are still desirous of having children or conceiving. So mine is to maybe to touch, I don't know if Dr. Yvonne mentioned about other options of adoption and surrogacy. I think also they are available for people maybe who would qualify for what she has gone through, and invite other specialists, especially if you have any gynae on board who want to give an input, or any fertility specialist, or any person who has something that burning that you would like to add or subtract on the presentation before maybe we go to the Q&A session. Also, maybe I can add something about the comparison about MPA and MA. There is some authors who are saying MPA is superior in terms of preventing recurrency, and MA is superior in terms of overall response. I think that's why Dr. Kesa was saying you're better off combining, rather sequential treatment. Maybe 1 month you do MPA, the other month you do MA before repeating an endometrial biopsy after every 3 months. Any input from the any comment? If there's none, maybe you can go through the Q&A. I won't be able to go through them, but I'll pick a few. One is about if you have any facilities for egg preservation in the country, and if yes, how long can the eggs remain viable following preservation? Any fertility specialist on board who would like to tackle that? Or Dr. Baraza?
Sorry, Doc, I missed the question. When I logged out, actually, I can't have access to the questions.
If there's any facilities that offer egg preservation in the country, and if yes, how long can the eggs remain viable following preservation?
Yeah, quite a number of facilities now, thanks, Doc, are able to do that. Even where I'm working at the EHS, we are doing that currently. So it's something that has taken shape in this country. In terms of viability, there are quite a number of conditions that you must have in terms of just ensuring that happens. More often than not, you must ensure that, of course, you have proper storage for nitrous oxide, nitrogen tanks rather, that are because we freeze them. And then you should be able to have continuous supply of electricity because it gets affected a lot with that. We haven't done that in this country for so long, but in other countries, they have been preserved for quite a long time. What we are lacking again in this country is the fact that we don't have a clear policy in terms of what are some of the interventions that may be undertaken towards that. Yes.
Thank you, Dr. Baraza. The second question, the type of chemotherapy and radiotherapy types that put a patient at risk of premature ovarian insufficiency. I don't know if Dr. Kesa would like to repeat on that. I think you touched on that maybe.
Yeah. Yeah, so I think there's no one answer, but for radiotherapy, it depends with the dose and the age, like I put up so the older you are, the more, the older you are, the lesser the dose that's required to cause premature ovarian failure. And then for chemotherapy, the alkylating agents are the worst in terms of permanent damage to the ovaries. And then the others to different degrees, but the alkylating agents particularly dangerous, I'd say.
And cyclophosphamide, especially for our scenario, we commonly use it for treatment of GTN. Sometimes, rarely, sometimes use it for ovary. Is the most dangerous or toxic. The other issue is if these patients who have lost ovarian function, is there a possibility of conducting ovarian rejuvenation, e.g. using platelet-rich plasma, the cost notwithstanding? I've never heard about that. I don't know if any.
I can speak to that, Doc.
Yeah,
there's quite some studies that have been done in relation to that. Using platelets, basically you do a centrifuge. The blood gets platelet-rich plasma, and then you infuse that in the ovaries. There are studies that have shown some good outcomes in relation to ovarian rejuvenation, but whether that translates to pregnancy is where we have positive data, because I think some studies that have been done in Cyprus especially they've just looked at a few patients, about 50 patients, and out of that, just about 15 of them actually got pregnant through IVF, though. We've not had very good success in terms of a normal pregnancy. There are a few other predetermining conditions that you may want to consider. One is the age of the patients. The younger the patient, the higher likely that they get pregnant or they have rejuvenation for that matter. And then also the type of insult or injury that happened to the ovary. If the insult was very significant, especially to the vasculature, then it becomes very difficult for the ovaries to rejuvenate. So it's an interesting area that still quite some data that needs to be undertaken, assets to be undertaken for it to be fully implemented. Largely still experimental, and I don't think in our country we've had this undertaken by anyone so far. Thank you.
Thank you, Dr. Baraza. I think also the following question is yours. Comment on ovarian fragmentation, follicular activation for premature ovarian insufficiency.
So those are some of the modalities that have been used. There are studies that have shown the role of DHEA in ovarian rejuvenation, again, the stimulation. But you want to balance between the side effects of DHEA. You want to balance between the natural ovarian aging process. There are some centers that have shown good results, but largely not in large studies. So they still remain more or less case study publications that have shown some results. So DHEA using platelet-rich plasma are some of the methods that have been used to rejuvenate the ovary. But one of the things that we need to really think about and consider is once aging, the natural aging of an ovary, ovarian tissue has happened, it becomes extremely difficult for you to reverse the process. We may have a reduction in the number of, or rather in the amount of FSH. You may have some slight increase in AMH levels, but in terms of getting pregnancy outcomes out of that becomes completely difficult for you to achieve. Thanks. Yeah.
And also the following question is, the cost of cryopreservation in Kenya, any estimates that you might know?
It's ranging between 80 to 150,000 per year, depending on the center. a number of centers have an average of 100,000 per year.
Okay, thank you. And maybe the following question on Dr. Wekesa, effects on fetus when the mother has cervical cancer, or effects on the mother when she's gravid?
I'm not sure what the question is asking, honestly.
If there's any effect on the fetus when if the mother has cervical cancer.
Okay. So what I've found, I mean, cervical cancer in pregnancy is a whole topic on its own, but what I've found, there have been case reports of babies who have been born, especially when they have vaginal delivery in early cervical cancer. We've had fetuses who have been diagnosed with and cancers of the bronchial, laryngeal, areas as a result of the, I don't know whether it's the inhalation or the the fluid, but there have been reports of cancer in the newborns. They can check that report, yeah.
Yeah, just maybe to add on, I did my thesis for fellowship on cervical cancer and pregnancy. By then, maybe things have changed, was that there was no effect on the fetus due to the disease, and there was also no effect on the mother because of the pregnancy in terms of baby cancer progression. What they were recommending is that if the mother is desirous of the pregnancy, then you can, and the disease is advanced, you can start, of course, chemotherapy after 16 weeks. For the OBGYN in the audience, we all know organogenesis ends up 12 weeks, but we give another 4 weeks window period for safety purposes. And then maybe you could deliver at 37 weeks, stop the chemo at 35 weeks, then deliver the mother at 37 weeks, and there were options. The preferred method of delivery was CS if there is advanced disease because the lower uterine segment is involved, and you do a classical incision. Because if you do transverse incision, your chances are you'll go through the tumor cells, and there'll be a lot of PPH. And if the mother doesn't want the pregnancy, of course, you can terminate the pregnancy and give radiotherapy. If the mother is for early disease that is amenable to surgery, you give chemo. After delivery, after doing the CS, after 6 weeks postpartum, then you can do hysterectomy. The people have tried to do radical hysterectomy intrapartum when they are doing the CS, but there are a lot of, bleeding and hemorrhage, so it's not advised to do it during intrapartum. Then the second question, the other issue is about, is hydrometria a sign of developing malignancy? Dr. Yvonne?
Indication that there's something going on with the cervix, therefore it's causing the stenosis and the blockage of the fluids. So it's an indication. You could evaluate the cervix just to make sure there's nothing happening with the cervical area. We've seen many postmenopausal women who present with hydrometria as the first presentation, and then later on the assessment of their cervix, you find they have a cervical tumor or an endocervical tumor. So I'm not saying it's an indication, but it could indicate that there's something going on with the cervix.
Thank you. So basically, depending on the age, if the postmenopausal lady, then there'll be high index of suspicion of malignancy. And the next question, Dr. Wekesa, is about the Peters criteria or Sellis criteria. And there's need for chemo or adjuvant treatment, so to speak. Will you advise a patient who is still adamant and wants to get pregnant?
I think we see this with every scenario, not just in cancer, but the best advice there would be to explain to the patient the risk of progression and recurrence if they do not go through with the chemo and radiotherapy, but also to provide options like we spoke about today, options of preservation of ovaries and other methods of making sure they can be able to still, go through their fertility journey. So the best way would be counseling, I'd say, but you cannot ignore, there's really no other option. Yeah.
Yeah, I think I agree with you, Dr. Wekesa. And of course, our work is to advise the patient and give them, the bare facts, and the last decision lies with them. And of course, always the patient autonomy carries the day. But as long as we have told them the pros and cons of the decision they want to take. And I think this question, you have touched on it a little bit, on effect on congenital abnormalities after oncological treatment. I think you mentioned in the previous answer you are tackling the issue of rate of miscarriage following trachelectomy, and how does the removal of cervix affect fertility? You want to touch on it, Dr.
Yeah, so again, when you look at all the studies that have looked at the rate of miscarriages, it really depends on how much is taken. So there's no one answer for this, but for sure, depending on whether you've done a simple trachelectomy, a radical trachelectomy, and a vaginal approach, or a abdominal approach, it varies. And this is not just because the miscarriage is not just because of the mechanical factors that are like the cervix is shorter, therefore likely to open up, but also because you interfere with the mucus plug. And when you interfere with the mucus plug, you have more ascending infection, and therefore they have more miscarriage from infections as well. So that is not a the rate varies. And how does removal of cervix affect fertility? Like we said, we have cervical factors that, okay, most of the studies say they're anecdotal, but I think maybe Chris can report on how much of the cervical factors in fertility they see. But mostly it's to do again with motility of sperms and stenosis and all that. So yeah, removal of cervix. I put up a slide with the percentages and all that, but removal of cervix definitely affects fertility.
And also the size of the length of cervix that remains. The recommended is more than 10 millimeters, that's 1 centimeter, for that pregnancy to be conceived through vaginal route, and or to have a lower, rather not lower risk, but basically most of the teaching recommends after trachelectomy, you should put a muslin or a Schrotka or a McDonald's tape after the procedure, so that can maybe mitigate or rather reduce the chances of miscarriage. And also you can touch on that, Dr. Case, about complications of, I think the author meant simple trachelectomy or radical trachelectomy. I think I've mentioned some in your previous.
Yes. Yeah, we talked about those. So majorly it's to do with what I've said. Radical trachelectomy is to do with cervical factors for infertility, so motility of the sperm, and then things to do with mechanical factors, so early miscarriage, PPROM, intrauterine infections, and then I think we also talked about the abdominal trachelectomy and their chances of, because it's a more morbid, more extensive procedure, they have less, live birth rates and ability to carry pregnancies to term because of more cervical tissue being removed. Don't know if there's anything else I left out.
So basically what you said, I mean, cervical stenosis, cervical incompetence, those are the key complications. And on the issue of, I think this is more of an, a question to any gyna, comparing use of muslin tape versus polypropylene suture in permanent cyclage during trachelectomy. I haven't come across it. I'm not saying it's not there. I don't know anyone among us.
Yeah, what I found when I was looking at this was really there's no much difference in terms of outcomes. At this point, it's more surgeon preference than anything else in terms of outcomes.
Then the other questions about maybe to the organizer about their CPD points, but I think those will be addressed later. To Chris Baraza, the implications of error in oncofertility, namely the risk of progression of cancer, death, were too high to suggest an option of cancer patients, regardless of staging. And I think this mainly, before we put patients to this treatment, we tell them the pros and cons of the options we're offering. And now it remains to the patient to make an informed decision, as, of course, the implications of course, disease progression or even mortality from that disease. But our work as clinicians is to guide the patient and for the patient to make an informed decision. I don't know if Dr. Chris, you want to add something on that?
Yeah, Doc, I want to agree with you.
Dr. Kesa.
I want to agree with you in entirety in relation to that. I think one of the most critical things we need to really do is, as you mentioned, is to provide information to the patient so that they can make informed decisions. We've had scenarios where you've had patients with advanced cancer, and then they tell you, Dr. Rimi, I want to get pregnant, get a baby fast, can you withhold treatment? Sometimes it gets successful, sometimes it doesn't get successful. So you need to really give proper guidance to patients. So patients that may go this option usually are patients that you are getting early on, that the options that we've talked about are more common. But patients who have mostly advanced disease, then you want to really advise the patient in terms of what are the potential outcomes. Sometimes the pregnancy can even worsen the cancer itself or the clinical condition of the patient. So you really have to balance between what the patient desires and what is clinically possible. At the end of the day, let the patient make an informed decision in terms of the treatment options that are available for them. Thanks. Back to you, Dr.
Thank you. And Dr. Yvonne Wakesa, in regards to preserving ovarian tissue for later transplanting back after chemotherapy, are there chances of transplanting malignant cells harvested prior to commencement of chemotherapy?
Sorry, I missed that, sorry.
Sorry, I can repeat. When preserving ovarian tissue for later transplanting back after chemotherapy, are there chances of transplanting malignant cells harvested prior to commencement of chemotherapy?
Wow, I don't know if there's a right answer to that question. Honestly, I have not come across that. I don't know if maybe Dr. Chris, I don't know if there are any checks and balances when they are doing the cryopreservation.
Maybe I may try to chip in weigh in on that. So basically, the issue is to the person who asked the question and to the audience. When we're preserving an ovarian tissue, you are preserving an unhealthy ovarian tissue. We're not preserving an ovarian tissue with disease. Of course, there might be chances. There might be chances because you see the scenario you are working is we have frozen section. Unfortunately, we don't. Wow, what has happened? Are you still on?
Can hear you, Doc.
Sorry, I don't know what happened to my screen. So unfortunately,
yeah, we can hear you, Doc. Very well.
Unfortunately, we don't have frozen section in Kenya that guide us the ovarian tissue you have removed is healthy or not. But on our clinical acumen, we prefer preserving the grossly looking normal ovarian tissue. And there might be chances as the question has been put. So if that happens, it means it will deploy the patient to having, harvesting it will be a challenge in terms of trying to get any oocytes from it or transforming the malignancy to the unborn or to the zygote, so to speak. Or maybe Dr. Baraza also can add on, anybody else.
Yeah, you are right, Doc. There's quite some publications around that. And one of the setbacks of having that ovarian, either auto transplantation or basically usually is that there's a risk of malignancy. And therefore, when you reimplant, then the tumor, again, just continues to progress following that. So as you mentioned, Doc, we don't have very clear guidelines locally on how to go about that, but there's some published data that exposes the patient to a risk of having progression of
Thank you. And maybe to go through so that in the interest of time, maybe two more questions. So last one. One is about to Dr. Baraza about comment on ethical concern in embryo stroke egg freezing.
Yeah, there are quite some ethical concerns in relation to that, and there needs to be very clear guidance in relation to how that happens. One of the things that has been asked is, once you do embryo cryopreservation, how do you date that baby? How do you say the age of the baby is? If you cryopreserve, for instance, an embryo for 3-4 years, and then you do a transfer after 4 years.
Okay.
There are some concerns there in relation to how do you do that. And then the other concerns are basically religious in terms of natural conception vis-a-vis assisted reproductive technology. So there are some religions that don't prescribe or align with that, and therefore that becomes also an ethical issue. The third one that comes in is the issue of surrogacy, and there are quite some ethical concerns that have been raised around.
Thank you. And lastly, to Dr. Yvonne Wekesa, in regards to...
Once we do, we come back to surrogacy, yeah.
Sorry for that. Lastly, Dr. Yvonne Wekesa, in regards to when should somebody think of getting pregnant after completion of chemotherapy or treatment, so to speak?
For which problem? I mean, for which malignancy? There are many factors. So
yeah, globally is recommended for 2 years because 80% of recurrence occur within the first 2 years. But sometimes because of age, you can't tell maybe a 45-year-old to wait for 2 years to get pregnancy. So some recommend after 6 months, after completion of, or rather after remission, you can start after 6 months. But the recommended cutting across bodies is 2 years, so that the issue of 80% recurrence is addressed or mitigated. And I think with that, we shall come to the end of today's presentation. First and foremost, I'd like to thank the two presenters, Dr. Wekesa and Dr. Baraza, for the wonderful and insightful presentation they have done. And also, secondly, to the audience for getting time out of their busy schedule and attending the webinar. And I hope they have some take-home messages on how to handle the cases we have, rather the issues we have discussed. And last but not least, to KNH management for giving us the platform to articulate and address matters pertaining maternal health. Thank you, everyone. Have a lovely evening and take care. And let's go for pap smear and mammogram and screen for any cancer that is screenable. Thank you.